Value-based healthcare benefits patients and caregivers alike, supporting resilience and achieving quadruple aims. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm your host, Tom Petterly, with AHA Communications. This special two-part series features speakers from AHA's most downloaded podcasts. In this first podcast, the AHA's Priya Bathija, Vice President of Strategic Initiatives, is speaking with Dr. David Perlstein, President and Chief Executive Officer for SBH Health, and Dr. David Zaas, Chief Executive Officer for MUSC Health, about how clinicians and hospital leaders can work together to achieve value and spread their efforts across the healthcare ecosystem. This session was recorded as part of the Architecture of High Value Healthcare Conference, which AHA co-sponsors with the High Value Practice Academic Alliance. Listen to part 2 of the conference this Friday.
Thank you, Drs. Perlstein and Zaas, for joining us today for this conversation. One of the frustrations that we've heard from the field related to our efforts around generating more value for patients is that different groups aren't speaking the same language. And this includes conversations between clinical leaders and non-clinical hospital leaders. So I'm looking forward to getting your thoughts on this and hearing some real-world suggestions for how we can better communicate and better design solutions together. So let's jump in. First, Dr. Perlstein, we can start with you, but how do you create a culture that prioritizes value?
It's easy. You just snap your fingers, just like everything. It takes a lot of work. You have to make it a priority. You need to build a trusting foundation so that you actually can develop shared vision. Leadership has to value those relationships, and you have to listen to your stakeholders. And I think that's a mistake that often people will make and leaders will make, is that they assume they know more than others. We're lucky at SBH. My board has always had CEOs who are doctors at the helm. They always felt that was an important kind of bridge for the clinical leadership. And that works for us. It's not absolutely necessary, but it does make it easier, because I think it does build almost immediately on a culture of mutual trust and understanding. So that's at least a start.
Yeah, thank you. And Dr. Zaas, what do you think? How do you build that culture that prioritizes value?
So I agree with some of David's comments. This is not easy work, but it's critically important. And I think the first is we need to define value. And I think there's a misinterpretation of what value is by a lot of our stakeholders. When people hear the word value, they immediately jump to we're cutting costs. And we focus a lot on, value is defined as the customer. Value is defined as, the impact of our services. And part of that, is safety and quality and service and cost, and really redesigning it. So I think if we define value correctly, if we focus it on the customer, that our care teams, our physicians, our nurses are really excited around safety and quality and service and eliminating waste. We lose them early if they misinterpret this push to value as, where are we cutting?
Yeah, I completely agree with you. So as you both are clinicians, you're clinical leaders, you are now CEOs. As the CEO, how do you want clinicians to look at value? What do you want them to come to you with, and how do you wish they would think? Dr. Perlstein?
Sure. So David's absolutely right. I think he really did target that definition of value is an important thing. But I think it also is important to remember that doctors are very high performers. However, it's also important for us to remember as management that at this point in our careers, we probably know a little more than they do about the details behind hospital management in general, some finance, I would say hospital finance, and politics and strategy. But that doesn't mean you hold it over them. So I think that what's really important whenever you're talking about value is get people at the table and do it early. Right? There's no way you're going to bring people in if you come up with a program and a policy and you hand it to them and say, do this. You're just not going to get buy-in. There's going to be an incredible amount of resentment. It's also important that they know that you're going to depend on them to guide you. Because just because I just told you I'm a doctor, so I understand everything they're going through, You can't play that card. It really doesn't work well. And you really need to just give folks a reason to help. And the fact is, it doesn't mean it has to be connected to some direct financial incentive. And I think that that's, again, it's one of the comments that David made just now about the idea of this idea of value. It often isn't the right approach, to tell you the truth. An example of something that we did in our organization was in our development of our value analysis program, we actually asked the chair or the director of orthopedics to actually chair the committee. And by bringing him in early, he was able to set agendas. He was able to develop programs around decreasing waste, which really allowed us to reinvest in his program. Mm-hmm. And he recognized that. And because he's a leader, he was able to bring that back. But it also is driven by our commitment to the quadruple aim, which we still follow. We do that through our safety calls, through our town halls, through our lean daily management rounds, and through value analysis. So I think it's multidimensional, but so much of it has to do with not ignoring them at the beginning. And if you do that, you really can get a lot of friends in this process instead of enemies.
Yeah, I think that's great. And I love the concept of bringing people to the table and making sure that you're being strategic about bringing the right people to the table to not only guide the conversation, but then be leaders throughout the hospital and health system to sort of bring about future change. David Zas, I would love to hear your thoughts on this as well, but also if you can flip it, right? And from a clinical leader's perspective, how do you want your CEO and the others in their C-suite to look at value? What do you want them to come to you with, and how do you want them to be thinking?
So thank you, Bria. I think there's two thoughts to start with, right? What we're talking about is change management, right? Fundamentally, right? It's how we engage between our clinicians and our administration in change management. And to some of David's earlier points, right, it's critical that when the hospital and the health system are coming forward, right, that it's really physician led, right? That we have a shared vision and we have a shared goal, but we can't dictate the path to get there, right? The hospital needs to be willing to, again, put out the bold goal, to set the vision, and to truly empower our physicians and our clinical leaders to get there. And I tell our hospital operational leaders, never start with the finance. Start with the care, right? The safety, quality, service. If you do all those well, the finance is the outcome, not the goal. I tell our clinical leaders, though, on the opposite side, to your question of what do you tell clinical leaders? And people say that people don't like change. I disagree. I think people really like change. We like it when we are leading change. We hate when change is done to us. So how do you help our physician leaders build their case, right? It's telling stories. And we're all good storytellers, right? That's we went to med school, and right, you listen to patient stories. This is storytelling. But if you're a clinician, if you're a department chair, if you're a leader, try and to, again, first of all, are you passionate about it, right? As a hospital operator, right, I want people that are passionate about their ideas, and that needs to come through. The other is the physicians need to be able to understand the value proposition, not just, right, the safety, quality, and service, but that they do pay attention to how it drives down total cost of care, how it improves our ability to impact others. And so I sort of counsel people opposite. If you're a hospital operator, if you're a non-clinician, start with the clinical, start with the why and end with the finance. If you're a clinician, make sure you're willing to understand the operational impact and that you've paid attention to it. And then both to commit to that we are really aligned. I think it's a misconception that our physicians and hospitals aren't aligned. If we define value, right, there isn't a physician on our medical staff, a nurse, or a hospital administrator doesn't want the best outcome for patients, who doesn't want the safest care, who doesn't want us to help more people. So I think making sure that realization, and then my final comment, Priya, is just I think on both sides, it's all relationships, right? We're in the relationship business. It isn't the smartest person. It isn't the person who's got the most innovative ideas. It's who can navigate relationships and how we coach and help our hospital operators and our clinicians. That's the critical success factor.
Dr. Pearlstein, do you have additional thoughts on that from your CEO seat?
I will tell you, I agree completely with the storytelling, but I think it's also, there are going to be disagreements, and that's okay. I think that what we're trying to do and what we're recommending is that in order to narrow the gap between viewpoints is to empower the less powerful. So you have to give people a voice, but it can't be the pretense of my voice is more important. And then also learning the concept of materiality. You know, if my director of orthopedics chooses something that's not going to save me as much money as something else and is equally high quality, but there's some other reason why he and his group are dedicated to this, and the difference is de minimis, then he gets to make that decision. Recognize you don't always have to win.
But I really like your comment, David. I agree that conflict is good, right? Mutual respect and conflict to ensure that we are doing what's best for the patients and families is really, really healthy. And organizations that can't have respectful debate and conflict, right, aren't going to be successful, aren't going to make the best decisions. And I think it's important. I mean, we talked to our team here. How do you practice conflict? How do you actually practice having that disagreement and that debate because it makes us better? And I worry about organizations where there isn't those relationships and there's that fear of having conflict, right? That they're not going to be sustainable. They're not going to make the best choices.
So, given all that you've shared, and I love all of the real suggestions that you've offered about sort of narrowing that gap in the conversation between, clinical leaders and non-clinical leaders, and then the point that we really are aligned on sort of this goal of better outcomes for patients. So, if you were talking to a CEO who's just sort of getting started on this and trying to have these conversations in the right and meaningful ways, what's your piece of advice to them as they get started?
David, I'm going to let you go first.
Okay. I think my first piece of advice to new leaders is really to focus on humble leadership, to really understand that leading in healthcare is different than leading in other organizations. And I don't know a health system or hospital CEO, an academic leader, clinician, non clinician, that truly doesn't role model the humility of leadership. And I think that it goes a long way with our physicians and nurses to be able to truly, sincerely demonstrate that. And I think over the last 18 months of the pandemic, it's even been more important, right? When you add stress to our care teams. So, right, to some of the earlier points, right, our hospital operators and our finance teams have a level of knowledge and expertise that our clinicians never have and never will want to have in their scope of expertise. Our clinicians have a range of clinical knowledge and skill sets and outcomes, but that humility to recognize each other's skill set and to value it. And I obviously will use my own example. I recently transitioned after almost 2 decades at one organization to coming here to MUSC in the setting of a pandemic and right in the time of stress and others. And I think that ability to show humility, to truly learn from others, to be open minded, and to really focus, right? As hospital CEOs, as leaders, our goal isn't how we get somewhere, it's getting to the outcome, it's getting that future condition and really being a coach, right? As a hospital leader, how many of our CEOs are we saying your job is to be the coach and to build a talented team? And so, right, I'm a big Duke basketball fan after almost 20 years, right? But it's hard not to like look and say to Coach K, right? Really good at getting talent, really good at letting that talent express themselves and being nimble and changing. And I would challenge all of us as hospital CEOs, right? If we could do that, we're going to have amazing results.
I love sports analogies, so I'm glad you brought in basketball to this conversation. Dr. Pearlstein, what are your thoughts on sort of getting started?
I think the humility of it all is probably the most important part as well. And I cannot agree more with David than I can express. Again, as I said, I've learned a lot. I've had good mentors. I'll tell you, one of the things that was very helpful for me in my career was looking for outside sources and talking to folks outside of medicine as well about management and learning some things about management. And I still, to this day, depend on a book called Crucial Conversations, because and I read that pretty early on, and I have forced most of my management to read it, because you can say almost anything to anybody, remembering that you have to remember what your goal is, and however you're expressing something or what you're saying, is that going to result in the goal you're looking for? And I spend a lot of time in my own head thinking about that. But I also know I'm not the smartest guy in the room. I'm very comfortable with that. But I'm also very comfortable that I have enough emotional intelligence that I can talk to people and get them to teach me more so we can be better. And as long as we all have that shared vision, and the vision has to be around what we do for a living, which is to take care of patients, then I think that we can't go wrong. But we will go wrong. And it's how you respond when you're wrong, I don't think also drives how successful you're going to be in the end.
I love your point about learning from others outside of healthcare. I remember when I went back to business school, and I loved learning from others outside of healthcare. And I think it's more important now than ever, right? As we have all are approaching digital transformation and redesigning our businesses, are we really going to learn from others in healthcare, or are we going to learn from other industries that understand how to approach customers differently and how to approach true digital transformation in terms of how we do our work? And I know I'm personally excited and love the examples outside of healthcare. And I think that's going to really lead to the transformative change, not incremental change. And I think we get stuck in healthcare leaders sometimes of getting stuck in incremental change, and that's not enough.
So we have a few minutes left. So I just want to ask you sort of one question. Given the period of time in which we're having this conversation, the pandemic is still very much a pandemic across our country. How does what we've learned in the past 18, 20, 22 months help us have these conversations around value? So what can we take away from this pandemic? Dr. Pearlstein, I'll start with you.
What can't we take away from this pandemic? I think there are so many opportunities to do better and be better. Certainly in my community, which is a very much an underserved community that really struggled early on with COVID, and we saw unemployment going up into the mid 20s, 20%. I think it was 24% at some point, which is terrifying. Everyone was impacted. My hope is that we double down on again, bringing back to this comment about learning from other folks, that we learn how to be customer friendly, that we learn truly be community centered and patient centered and make decisions that actually serve our communities before we start thinking about our own needs. Healthcare is still stuck in that world. We can't get out of our way. We think we're patient centered, but we're really not. Otherwise, our scheduling would be very different. The way we do procedures would be very different. And I get it. We're complex organizations. We don't want to make a mess. But I'm hoping that COVID forces us to look at our investments in keeping patients out of the hospitals, truly. I would like nothing more than for St. Barnabas as an inpatient facility to be able to shut down, because I basically have decreased the need for inpatient hospital beds. I don't think that's going to happen, unfortunately. I don't see the investments out there right now. But that would be a positive thing for us.
That's great. Dr. Zoss, any closing thoughts?
There's so much. I mean, I think all of us would make a few comments to say that, especially as leaders, right? It's been an honor and a privilege over the last 18 months to watch our teams respond. And I'm sure David would say the same thing, right? We could tell countless stories of the ability to be nimble, the ability to innovate, the ability to work through stressful situations, and the team building and others. And right, it is hard that I don't think we express our gratitude to our teams enough and appreciation, and realize, right, we in healthcare have the honor and privilege to work at this time when it's so desperately needed, but especially as hospital CEOs, health system CEOs, right? We really are thankful for where we are. Maybe I'll throw out, and there's a lot of good things that are going to come. We're going to be better at the end, but I don't think we've fixed the biggest challenge, which is how we do the work. I think when you look at where we're at, and here in the South, right, the Delta variant and the surge and the staffing challenges, which are nursing, but every area across the organization, And I think we are all focused on recruitment and retention and bringing in people, but we're still looking to the old model. We're still looking to rebuilding what the old team looked like and how many nurses do I need to hire and how many PCTs and techs. And I'm worried that we're never going to get back to that. COVID is going to be here for years. The staffing shortage will outlast that. And I don't know the answer, and I'm not smart enough to figure it out, but I think our teams will, to say, how do organizations learn to deliver care differently? If you assume the demand is going to continue to grow and the old staffing model can never be sustained, we need to have a burning platform to say how we deliver care. The role of physicians, the role of nurses, the role of teams is going to be totally different. And I don't know, and would love to be part of a group to say, how do you design that? People come up to you, right? When are we getting back to normal? I think we should put it out there. We're not, that was the past, and we need to start looking for the future. And I would love, as David says, to be delivering more care in the home, but I would love to even redesign the roles and care teams that we have today. And in my ideal state, right, it would lead to less burnout. It would lead to truly being the best place to work. But if we don't do that, we're going to struggle to recruit talent into healthcare.